Welcome to Fuzzybutts and Friends. Well, as much as it drives Fuzzybutts all over this place absolutely crazy whenever they hear me say it, I am the host of the show, your big dog, Luke Robinson, and we're happy to have back with us this week. She's our co-host and occasional co-pilot, and she is the co-producer of Fuzzybutts and Friends. I think I leave that out every episode.
Acknowledge me. Thank you.
Yes, she does a lot of work in the background. It's Ginger Morgan. She's the executive director of the Puppy Up Foundation. Ginger, how are you?
I am doing well. And how are you? Like I said the other day, nobody asked you. How are you?
I'm well. It's becoming spring. I'm spending more time outside with the Fuzzybutts, so I'm ready to go. Let's get this year on the road, as they say. Well, I'm as you know, Ginger, we're still early on into season 2. And one of the big projects that you have helped me put together this season, is our series on canine cancer. And we've had some wonderful medical oncologists on so far to talk about lymphoma, hemangiosarcoma, and mast cell tumor. And this time we're taking a little bit of a turn, not too much, too far out of the woods, to have a surgical oncologist with us today here on Fuzzybutts and Friends. And on that note, I'm happy to introduce it's Dr. Arathi Vinayak. She's a surgical oncologist. Dr. Vinayak, how are you? Welcome to Fuzzybutts and Friends.
I'm doing good. Thanks for having me today.
Thank you for being here. I'm probably going to do a bad job of pronouncing your name sometimes. If I do, my apologies. My brain occasionally moves faster than my mouth moves faster than my brain sometimes. So my apologies.
No worries.
Sometimes.
All right, we like to start this show, since it is Fuzzybutts and Friends, and it is, even though we do talk a lot about cancer and dogs and cancer and Fuzzybutts, we do like to start the show with a little bit of fun and talk about Fuzzybutts. So do you have, Dr. Vinayak, do you have any Fuzzybutts there at your home?
I sure do. I had to put them out of the room so they didn't walk in front of the camera today. So there's 2 of them that we have now. We lost our dog recently, but we have 2 cats at the moment.
I'm sorry to hear that you lost your canine Fuzzybutt. What happened?
Cancer.
Oh no, no. Are you emotionally okay to talk about the specifics, or is it still pretty raw?
No, I mean he ended up with what I think a lot of older dogs pass from. So he had metastatic hemangiosarcoma. So
what was his name? What's his name?
His name was Stages.
Stages?
Stages.
Stages.
That means brave in my language.
Got it. That's a unique name. I love it. Well, I'm so sorry for your loss, and hemangiosarcoma. That's a tough one. Ginger, here at the Morgan Manor and the Puppy Up family, we lost recently a dog Sadler to hemangio, to metastatic, and that's a tough one. So I'm very sorry for your loss. Well, how did you, Dr. Vinayak, how did you get involved in surgical oncology? Tell us your origin story.
So my origin story is that I got into vet school just knowing that I wanted to help small animals, but didn't really think that I either wanted to be a surgeon, much less in the field of oncology. That's kind of just evolved over time. I got into vet school thinking I'll be a general practitioner. And as the years of vet school went on, I realized, well, I really like surgery. But 20 years ago, women surgeons were just not a thing in veterinary medicine. Women in general in veterinary medicine was just not a thing like it is now, right? Vast majority of veterinary students now are female, right? And now the men are a lot smaller in proportion, but back then it was mainly a male dominated field, and forget about getting into surgery. So I remember 4th year vet school asking the surgeons at University of Georgia, like, I think I want to do this. And can you help me? And their answer was, no, I already have all of these guys that I'm helping. So I didn't get what I needed from vet schools. Then I thought, okay, well, during my internship, I'll find that somebody will want to help me. And again, during my internship, everybody said, well, you're great in internal medicine. That's where you should go. You're a med head. And that's what I heard. And I was like, well, I appreciate the fact that you think I'm smart, but why don't you think I could be a surgeon? So it was a tough uphill battle, I would say. And there was a surgeon, DJ Crawwinkle, back there at University of Tennessee, where I was doing my rotating internship. And I remember him saying, if the average male applicant publishes 4, you're going to have to quadruple that to even be heard, to even be seen. And I remember thinking, my God, like, how do I get 4 publications of a rotating internship? Like, I'm already a slave labor, right? You're working endless hours as a rotating intern, always on call, always working overnight, just sleeping in the hospital. They had bed quarters upstairs for us. So we would man ICU, see emergencies, work all day the next day. And there were no really labor laws 20 years ago. Like you can't work, 48 hours in a row like we did routinely as interns. And I'm thinking, my God, how do I get publications done? But I found at University of Tennessee during my rotating, some really great mentors who said, okay, like, let's get you seen, let's get you heard. And if you want to do this, let me help you. And so that was the start of getting publications. I had one already 4th year of vet school, and then I got 3 more during my internship. And I fortunately matched, which was great, with a surgery residency at Texas A&M, where they had other female residents. So it was great back then for me to get into the field of surgery. And I thought orthopedics was my jam. So I stayed in academia for a little bit after my residency. I was surgery faculty, mainly orthopedic faculty at that, then spent the next 10 years as a general surgeon, cutting both soft and orthopedics, with really orthopedics thinking that was my jam. And over time, I realized I really liked the nuances of complicated soft tissue surgery. And I found that I was really good at it. And then I thought I could be doing cancer surgery better, because I started reading articles of what I was taught were inoperable tumors being operated on. And I thought I could be doing this better. And what do I need to get there? And how can I treat cancer patients better and do the inoperable every day? And so I went back, which is not a done thing, but I was out for many years post-residency, went back and did my postdoctoral fellowship at Colorado State University. And most fellows are right after residency. It's you do your residency and you go into fellowship. And I was quite an oddball that they took for a fellowship. I had been out for many years. And I think that was better for me. I can't speak for other people, but I think it was better for me because it helped me hone my surgery skills. I was a much better surgeon going into my fellowship. So I think what I took away from that fellowship is very different than what I think I would have personally taken out of it right after residency. Right after residency, you're still learning how to be a surgeon. And I felt like that portion of the equation was gone. I was already a full-fledged surgeon. And so looking at some of the complicated surgeries that we were doing during the fellowship, I think had I come right out of a residency, I would have thought, there's no way I can replicate that. But where I was in my career, I looked at that and I thought, I can replicate that. And I think there's certain things I could tweak on what I'm learning right now to make it better for me and maybe better for my patients. So that was my story. So I went back, I did my fellowship, and now for the next decade of my life, I've now been in private practice with a sole focus of surgical oncology. So this is my 20th year post going into the field of surgery.
Congratulations and cheers to you for sticking to your guns. I'm a firm believer in that. Wherever you feel like your path is, that's where you're going, no matter the adversity. So cheers to that. Well, Colorado State University, that perhaps is the most notorious institution to learn surgical oncology because of Steve Withrow. He's sort of the grandfather of veterinary oncology, and he was a surgical oncologist. Did you have a chance to work with Steve?
So Steve had just retired as I got there, but I did. So my first publication for my fellowship was actually with Steve Withrow.
Congratulations.
Wow.
He was lovely. So I've had other publications prior to then, but that's one of my most memorable publications was he was sitting in his office. He'd come back from fishing. He was semi-retired by this point. He had his tackle box, he had his fishing poles, and he was sitting there, and I couldn't find anyone to help me. And you needed at least one publication to credential again for surgical oncology. And I thought, oh my God, like, I can't find anybody who has a project readily. They were like, let's think on this. And so I was like, Withrow will know. So I walked in, I introduced myself, and I said, hey, I'm the new fellow. And do you have anything that I could look into and publish that you think is really cool and would stand out? And so he really was instrumental in that. So he was great.
Yeah, he's probably off fishing in his retirement and also making wedding floral arrangements. I had a chance to listen to him at VCS a couple of years ago or several years ago, and he said that's what he loves to do in his pastime, and it just didn't sync with my image of Dr. Withrow, but he's a wonderful guy. And
wonderful human being too.
The second dog I had that had cancer, Murphy, was nasal adenocarcinoma. We took him to CSU. Steve took a look at him, and he's like, "Yep, no, this is a case for radiology oncology, radiation oncology, not a candidate for surgical." And as you know, Steve likes to cut into everything. So for him to say Murphy was not a candidate was tough. So we did IMRT there at CSU. So I love that place. It's a great place to do a fellowship. So you got a wonderful origin story, Dr. Vinayak, and let's talk. Oh, I had a question for you. It's a bit of a controversial one, but I made a note of it, though. I do like to get in a bit of controversy. So we know that now that women are comprising more of the veterinary oncology community more than men. So which do you think are more competent in veterinary oncology, men or women?
I think equally so. I know wonderful oncologists that are both male and female, like Doug Pham, who's a med onc at CSU. Like, he's unbelievable. Steve Withrow, unbelievable. Bernard Segay, unbelievable. But by the same token, there's some unbelievable female surgical oncologists too. Nicole Earhart, like, she's a god, period, for men and women in surgical oncology, right? Like, you have some unbelievable, I think, surgical oncologists, radiation and medical oncologists, male and female. I don't know that there's a difference.
Yeah, Nicole was a part of our scientific advisory team at the Puppy Up Foundation, so we know. And I was being cute. Yeah, I've met a lot of them. Why do you think it is, though? It does beg a curious question, though, Dr. Vinayak. Why do you think it is that there is that shift in more women now going into veterinary oncology than men?
And I don't think it's actually specific to veterinary oncology, because like back then it's just surgery in general, right? Surgery in general in human medicine as well has traditionally been a male dominated field. I think you think surgeon back in the day, like you think guy, right? And I don't know why that ever was. Maybe that was like, you know, from the 60s, like that was the mentality. But I think the paradigm has shifted. And I think now they're just choosing candidates not based on gender, just based on who's actually applying and what their qualifications are, honestly.
And you're currently practicing at VCA in LA. Is that correct?
So not in LA. So there's VCA West LA, and that's a different hospital than VCA West Coast, which is where I am. So
Okay.
VCA West Coast is in Orange County. So it's the counterpart of West LA.
All right.
Is that in Fountain Valley or is that a different one?
No, that's in Fountain Valley.
Okay, I was there a few years ago and I think I met you, but everything really went fast that day.
Yeah. VCA West Coast is the newer hospital. It's the counterpart of West LA, except on the Orange County side.
Okay.
Yeah, we love VCA. You guys are doing some wonderful things there, and that you own or manage 25% of veterinary practices in the country is a wonderful thing, especially as it pertains to hopefully data collection and data analysis. So VCA is doing some wonderful things. One of the things I like to sort of start our conversations with veterinary oncologists with is just talking about what you're seeing generally in cancer in the canine population. What are you seeing out there on the West Coast that you want to share with the audience? Trends or cases or interesting cases that you're seeing over there on the West Coast.
Okay, perfect. I think, you know, if we can back up a little bit, I think it might be interesting for people to know what the difference is between a surgical oncologist and other oncologists, because traditionally, when you say, I'm going to go make an appointment with an oncologist, even 10 years ago, that was a medical oncologist. They were known as, you know, I'm going to make an appointment with an oncologist, was the medical oncologist who mainly specializes in treating cancer with chemotherapy and immunotherapy. And then now that's no longer the case. If you say, I'm going to make an appointment with an oncologist, the question is, which oncologist are you talking about? Because there's 3 divisions of oncology, right? You have medical oncology, that's chemoimmunotherapy for treating cancer patients. You have radiation oncology, where they specialize in radiation to damage the DNA of rapidly dividing cancer cells. So it's a non-invasive modality, and that's radiation oncology. And then you have surgical oncology, and surgical oncology generally specializes in quite a few things. We help diagnose cancer, so we're involved in the biopsy portion of it. We help stage patients, because that's an intraoperative thing that we do where we can inject dye and we trace them to the nearest lymph nodes that they're going to. So that's part of staging and determining the extent of disease. Then we also remove cancer, right? Either fully or debulk it from a cytoreductive standpoint. And then we're also the supportive service and the preventative service in terms of we support medical oncologists because we have to place vascular access ports for chemotherapy or pleural or peritoneal ports into the chest or the abdomen respectively so they can instill chemotherapy directly into body cavities. So we place those surgically placed ports. And then we're also preventative service because we remove tumors that have the potential to convert into malignancy. For example, carcinoma in situ of the rectum. Before it turns into full-blown colorectal carcinoma, we go in and we remove that. Or jaw tumors like epilysis, like acanthomatous amyloblastoma, we now believe that's on the spectrum to squamous cell carcinoma. So we get it when it's still an acanthomatous amyloblastoma before it turns into full-blown cancer. So we're also on the preventative surgery side of things is where surgical oncologists fit in now.
Yeah, that's a great point. Thank you for prefacing our conversation with that critical distinction. But I do want to point out and talk to you about the fact that it's not really a binary decision. Let's take the case of Murphy and nasal adenocarcinoma. Let's just assume that Dr. Withrow felt like he could get most, if not all, of the tumor mass, and so then for the pet parent, the client, or really the patient, like myself or like Ginger here, it's a really tough decision. Do I go with radiation oncology? Do I zap the tumor? Do I try to take it out? So how do you counsel the pet parents, your patients, help us navigate through that murky of water of when to cut out a tumor, when to pursue chemo or radiation therapy?
That's right. So the amazing advantage is that no matter which oncologist you start with, I think we're all going to give you all options. So I always tell all my clients and my pet owners, keep an open mind, come in, listen to all the options, but make sure you have a goal in mind because whatever options we give you, it has to line up with your goal. So for example, I can do some crazy big surgeries, but that may not line up with that goal of that pet owner, right? They come in, they get that consultation, and I always ask them, does this surgical option line up with your goal? And if it doesn't, then we say, okay, if this is too invasive, let's move on to other options. And here are your other options. That's radiation, so we can shrink it down and we provide comfort and durable palliation. We may not potentially get the survival time that we could get with a big surgery, but maybe that big surgery is not your cup of tea. So for every client, you have that line in the sand, and that threshold for what they will or want with their pet through is very different. I see all manners every day. So I see the clients who will say, okay, if I do nothing, my pet's going to die from cancer. It's 100% probability that my dog is going to die. So I'm going to take this big radical surgery with a 30% chance of mortality because that gives me a 70% chance at life and longevity, not just life, but longevity. So it's worth it to them to take that 30% risk and go down that path. But for another client, that same statistic doesn't sit well with them. They say, my God, there's a 30% chance of mortality with this big caliber surgery. Like, that's definitely not for me. So then they'll say, I don't want to go down that path. I want to go down a less invasive path. So one of the things we counsel our clients before they come in, we have a welcome letter. We say, please think about your goals before you come in, because that helps when we give you all the options for us to help you make that decision, because that right decision is going to be different from one client to another. I will give the same options for that same cancer for two different clients, and those two clients are probably going to choose very differently because it depends on what lines up with them.
Yeah, it is the greatest onus, and I think the greatest responsibility that a person can have is to make medical decisions on the life for the life of another, whether it's a child or a companion animal. So from the pet parent's perspective, Dr. Vinayak, we rely on you and your colleagues 120% to help us make that best decision, because we can all have sensitivities when it comes to statistical outcomes, but it's relying on the fact that, you know, that you guys know, first of all, not only know what you're doing, but second of all, is that you're conferring amongst yourselves. So what I like about in the veterinary oncology community is, in the typical scenario, you're conferring with a medical oncologist and a radiation oncologist to make sure that behind the scenes that you're making sure that surgical intervention is the next best step, correct?
That's right. That's right. And surgery is not always the right answer. We know that all the time. Clients may come in saying, I want this tumor removed from my dog. And I take one look at it and I say, there is not a possibility for me to be able to remove this tumor. So you have to do, at the end of the day, what is right for that patient. A lot of our patients and a lot of our cancers are quite complicated. So you have lots of options that can be quite difficult to help clients navigate, because you have a surgery option, you have a radiation option. It's a pure primary option, right? You can just go straight with surgery. You can go straight with radiation. You can do a combination. And so it's a variety of factors that then help that pet owner make that decision. What is your goals for the pet? And finances do play a role in all of that. We can want to do everything, right? So what may be absolutely the best for that patient may not always translate to what's actually done, because what may be really best for that patient may be cost prohibitive.
Absolutely. And unfortunately, that's the case. And it seems like the cost of care is increasing. And so that becomes a bigger problem. So sometimes the financial considerations do determine the type of therapy. Can you give our audience general guidelines as to which types of canine cancers are the best candidates for surgical oncology and which ones typically are the worst?
So I would say patients that are cancers that are mainly treated primarily with chemotherapy as the mainstay, you're probably not good to come see a surgical oncologist, because we can't remove metastatic cancers. So for example, I would say if you have metastatic hemangiosarcoma, we're unlikely to make a difference from a surgical standpoint, right? We can remove the bleeding spleen, but if there's metastatic disease, we're not really getting anywhere. Lymphoma, multiple myeloma, metastatic disease, really anywhere, if it's in multiple body cavities, we're unlikely to make a difference from the surgical standpoint. So surgery is a localized disease, local regional disease removal, meaning cancer is confined to one part and maybe the lymph node, right? Because we do remove regional lymph nodes. Anything beyond local disease and regional spread, we're probably not the best candidates, right? Or best oncologists for the task, because there's only so much we can remove from a cancer standpoint. So the kinds of cancers that surgical oncologists see on a daily basis, we see anything that are from simple external tumors like sarcomas, mast cell tumors. Really, there's a plethora, squamous cell carcinoma of the skin, like you name it, anal sac adenocarcinoma. We remove those in metastatic lymph nodes all the time, right? So anal sac cancers, splenic tumors, liver tumors, lung tumors, you name it, skull tumors, jaw tumors, maxillary tumors, eye tumors, like we do it all. We're able to remove a great number of things. So I think if I were to list the number of cancers that you would come see a surgical oncologist, I think I would speak all day, because there's so many tumors that are removable, and we've made so many advances in the field of surgical oncology. 70% of localized cancers are cured. That's the stats in humans now with surgery alone. It's
Wow.
one modality where 70% of localized tumors are cured with surgery alone. I would say roughly that probably translates very similarly to veterinary medicine as well. I would say 70% of localized tumors that I see on dogs and cats we're able to cure with a good surgery. But the key is to catch it at the right point before it is too large, before it's had a chance to spread.
But that's kind of the conundrum, though, with our canine companions, though, because we know that because of pain threshold differences between species, dogs tend to not show or represent symptoms of cancer until the disease is fairly advanced. So you feel, even though when you see good candidates for surgery, that 70% is still the number? That's incredible.
It is, because preventative medicine has become key in veterinary medicine now. The focus back in the day was wait until your pet is sick to do something about it. There is a change and a shift in the paradigm in how veterinary medicine, veterinarians are now dealing with preventative medicine, and pet owners too. Pet owners now routinely in California, when they have their 8-year-old dog go for a dental, if the veterinarian doesn't recommend it, and the veterinarian almost always does, will say, I want chest x-rays, I want lab work, I want abdominal x-rays to make sure that my dog is otherwise okay at the age of 8 before you put him under anesthesia. And now we are catching what we used to think were incurable cancers like anal sac adenocarcinoma, because we would see them back in the day, 20 years ago. There's been such a shift. We would see these anal sac cancers when they were massive, destroying the entire anus, metastatic everywhere, and that's how we would see them. And now routinely, I will get referred pea-sized anal sac adenocarcinomas, and now the literature says the median survival time for those guys is 1,200 days, which at the age of 12, when you pick up that anal sac, pea-sized anal sac adenocarcinoma, that dog is going to live out its complete lifespan and then pass from other things and not from this. So I do think that preventative medicine has come a long way. There was a recent study looking at 3,400 dogs and cats diagnosed with cancer, and this is in the United States. And the median age at which cancer was diagnosed was 8.8 years, which is a lot younger than what we've traditionally been looking at, right? So traditionally, the numbers that are thrown around is 50% of dogs over the age of 10 are going to die from cancer. That's actually a proven thing. That's a published number. That's a staggering number, that half of our canine patients are going to be diagnosed with cancer or potentially die from cancer once they're over 10 years of age. But 8.8 years is actually earlier than that 10-year number that we've been thinking. And so the point of that article is that we need to be doing preventative screening 2 years prior to that point, meaning we need to start screening patients preventatively at the age of 6. And for certain breeds, like extra giant dogs, right? Great Danes and other patients where their median age is a lot younger, we actually need to be staging those patients and screening for cancer even younger than that.
Absolutely. I am a father of Great Pyrenees. So the whole great thing means they're automatically susceptible for bone cancer.
At a much younger age, right, than all the others. So the median age for these giant breed dogs is a lot less. And so that article was great because it broke down what the median age was per breed. And in general, overall was 8.8 years, and saying we need to be screening at 6. I think if we are better about screening patients, and I think veterinarians are in general, I can't tell you, like, I mean, they catch the smallest things early now. I think compared to where we used to catch things before, so that cognizance is there both on the part of veterinarians graduating from vet school now, as well as pet owners. I think everybody's more vigilant now.
Yeah, I've been saying that.
I was going to interject for a second. So with my dog Lily, it was her behavior. People are probably tired of hearing me say the story, but this is kind of relevant because her eating habits changed. She would eat the same amount, but at different times of the day. So I took her to my vet and had an ultrasound done, and she had a stomach tumor. And so when I took her to University of Missouri, and I was talking to the surgeon, and they're like, well, how did you know that she had it? I was like, it was a behavior. And so once they removed it, I was asking, what's the prognosis? And they're like, we don't know because we've never had anybody find it this early. A couple years later, same thing. She had a GIST tumor and had that removed. And the first one was in 2018. The second surgery was in 2020. And she just celebrated her 15th birthday last November. And she's given me the what for every day.
Well, I've been saying for years, because I've traveled all around the country. I've met thousands of cancer dogs, talked to veterinary oncologists all around the country and even outside the country. And I've seen, let's just take bone cancer, for example. I've seen Bernese mountain dogs that have been diagnosed with osteosarcoma as early as 1 to 2 years old. So I've been saying, hey, guys, we're seeing cancer being diagnosed at earlier ages out there. It's no longer a disease of old age in companion animals. So it's great to have that research now that presents that case.
Yep.
In the case of, I want to go back to the case of Malcolm and osteosarcoma. You said something I think that's key earlier about your field, surgical oncology, is that I read a book, I think a few years ago, The Emperor of All Maladies, and they had the book perfectly presented the evolution of cancer treatment in humans. And I liked how they they sort of stage it out that, historically, there really only have been three types. Either you're going to treat it with a chemical poison, which is chemo, you're going to irradiate the hell out of it that has its own problems, or you're just going to cut everything. You're going to cut as much tissue. And that was before I understood the concept, but really appreciated the concept of radical surgery. So you use that term earlier. And when Malcolm in 2004 was diagnosed with bone cancer, we were still, that was a long time ago in the field of veterinary oncology. But the surgical oncologist that did the surgery for Malcolm, nobody there prepared me for how radical and dramatic the surgery was going to be. But that was 20 years ago, almost, it seems. And so can you talk to us about what have been some of the advances in surgical oncology? How have you become more precise? Have you gone now from radical to more precision surgery? So talk about that.
So I think in terms of advances in surgical oncology, there have been so many. Our imaging has been key because we have some unbelievable imaging modalities now. Ultrasounds come such a long way, and we barely even use ultrasound in our hospital. We have 5 oncologists, different, right? 2 rad oncs, 2 med oncs, 1 surg onc. Then we have a plethora of general surgeons who are also doing cancer surgery. We have so many specialists, and we CT nearly all of our patients because the CT scanners now the rendering is unbelievable. I can look at that tumor in multiple planes, have the computer manipulate the image the way I want it, and the computer will give me a 3-dimensional rendering of the blood supply to that tumor. So I can spin it around, and I have a really good idea for complicated surgeries where what I'm going to encounter and what the potential pitfalls in surgery may be, so I can be better prepared for it, right? So I think imaging has come a long way compared to the dinosaur CTs we had 20 years ago during my residency, compared to the spatial resolution and the clarity that we have now. And we have color rendering, which is unbelievable for our CT scans. So we've really come a long way. Our MR units are now 1.5 Tesla units. Some hospitals even have a 2 Tesla unit, which is, again, incredible for the kind of image quality that we get. And imaging is key. I think the field of radiology has come a long way. It used to be we would get readouts, there's a liver tumor, and now they're able to be very specific. It's not just a liver tumor anymore. It is on this portion of this lobe, and it's these dimensions, and all of those are really useful to us, right? Other than that, fields of surgical oncology, like we lymph node map now on a routine basis. Lymph node mapping is where you have different dye agents that you can use. Everybody has a different preference, but you inject the tumor and then you follow it out in surgery. You see what lymph nodes are the at-risk lymph nodes. We call those the sentinel lymph nodes. So we're going in and we're looking at sentinel lymph nodes, and then we're also tracking 1st tier and 2nd tier lymph nodes. So that's, I think, also changed, and it's, prognostically, it's been shown over and over again for tumors like anal sac adenocarcinoma, and now especially with mast cell tumors, that removal, those animals that had their at-risk lymph nodes removed are living much longer. And so now the standard of care for mast cell tumors is we not only remove the tumor, we remove the at-risk lymph node. I don't ever remove solitary mast cells anymore. I stopped that maybe 8 years ago. It's the mast cell and it's the nearest at-risk lymph node, because the publications now are many showing that subset of dogs, regardless of grade of mast cell, whether that's a low grade or a high grade mast cell, those dogs that have had their at-risk lymph nodes removed are substantially alive for a longer period of time than those that didn't have their lymph nodes extirpated. So just the cytology of that lymph node is not enough.
Do you do that? I just lost my 3rd dog to cancer, to metastatic mast cell cancer, but he was a cancer survivor. Hudson was a cancer survivor for 10 years. So if you think about it in terms of outcome, it was a tremendous outcome. But one of the things I think that helped in prolong his outcome or longevity is the marker diagnostic tests that you can do that weren't available a long time ago. And so for every tumor that we biopsied, we looked at the mitotic index. So do you remove the lymph nodes near proximal to a mast cell tumor, even if the tumors have like a low mitotic index, even if they're slow growing?
Period.
Wow.
Period.
Wow. I haven't heard of that at all.
So if you look at the newest literature, even low grade mast cell tumors, 1 out of every 2 dogs with mast cell has early spread to those lymph nodes. Cytology might miss 1 out of 2, staggering statistic that came out. That this has now been 2018 when that came out, and that's something we'd already been realizing clinically. So at CSU, like, you're trying to pull every regional lymph node, and we'd made that realization. So every fellow that was already coming out of CSU was like, we need to be pulling these at-risk lymph nodes, because, you know, every 1 out of every 2 dogs seems to have a positive node that we would have just never picked up on unless you had histopathology, not cytology, but biopsy of that lymph node. And now if you look at the literature, even the low-grade mast cell tumor dogs, those that have had their at-risk lymph nodes extirpated, are alive hundreds of days longer than those that haven't. So this is now, because you don't know what the grade is when you go into surgery, right? You don't know if that's going to be a grade 2 low-grade mast cell tumor or a grade 3 high-grade mast cell tumor. So you treat every lymph node like it's at risk, and we do pull every lymph node for every mast cell tumor dog.
That's something else. Yeah, that's certainly not out there in entirely in the veterinary oncology community, or at least that's the first I've heard of that study. That's phenomenal.
It's true. So if you talk to any surgical oncologist, they're going to be extirpating those regional lymph nodes.
Yeah, that's very, very important information. Well, you've done a tremendous, you have a tremendous corpus of research that you've done. As you said, you had to do a lot more research to remain competitive. Can you talk, Dr. Vinayak, about some of the interesting patient cases, some of the interesting areas of research? I like it that you've not only done osteosarcoma, but liver lobectomies. You've done some very complicated surgeries. So can you talk about some of the more interesting cases?
Yeah, so I think in terms of research, I'm like a squirrel, like everything's a shiny nugget. So I'm unable to just commit to one thing. I'm sure you saw my CV. Like I'm unable to just be like, I am going to focus on oral malignant melanoma. Like, so if you, in the last 6 years, I have melanoma publications, I have osteosarcoma publications, I have chondrosarcoma publications, I have a lot of liver publications, I have anal sac adenocarcinoma publications. So for me, I think every cancer, I find cool things. I have a research intern, clinical research intern that I take on every year. And this current intern says, every day I come up with, I was like, wouldn't it be so cool if we looked at X, Y, and Z? And he says, if he had a quarter for every time that came out of my mouth this year, like he would be a wealthy intern. That his intern salary, because I find things that I think that should be looked at every day for nearly every tumor, that I'm like, wouldn't it be so cool if we had this information that we should be looking at? There's not enough hours or time in my schedule to be able to do all the things that I want to do. But yeah, I mean, I think research is so important. I think there's so much information that we still don't have. I think in terms of like cool cases that I do, I feel like I do cool cases all the time. Like everything is exciting because I feel like every liver tumor is different. It's never just, I'm going in to do a liver tumor. My nurses feel that way because we do mainly livers, adrenals, and complicated. Like I can't think of the last time that I just had a small mast cell or a small sarcoma. I've become tertiary referral, so I only get all the ones that none of the surgeons in Orange County, and there's 40 plus surgeons just in Orange County. So I get all the cases that nobody else wants to do. And then I also have clients that fly in from Hawaii. I have one from Tulsa, Oklahoma, that Oklahoma State and Texas A&M and all the private practices don't want to touch. So that dog with an adrenal tumor is coming to see me in 2 weeks. So I take all the cases that are really difficult. So I feel like I do some really cool things all the time, and I find something different about every case. No liver tumor is ever the same. I find the same to be true for no adrenals ever the same, no jaw tumors ever the same. Everything is really cool and exciting, and we get to do some really cool things, I think, from a surgical standpoint and by that longevity. So it might be a higher morbidity procedure because it is a big procedure, but then we're able to establish a good quality of life and length of life at the end. I'm a firm believer that if I can't get good quality of life and longevity, it is not worth doing that big radical surgery. It's not worth it. I wouldn't do it in my own dog, so I would not recommend it for someone else's pet either. Right.
Boy, if we could just get some of those. Do you have 40, do you say 40 surgical oncologists in the LA area? Is that?
No, surgeons.
Surgeons. Okay. I was going to say.
I wish. There's only 60 something in the whole world for veterinary surgical oncologists. If we had 40 in Orange County, that would be the most amazing thing ever. But
well, I know your community, I think in total veterinary oncologists is still less, around 500, 600, I think in total in the country.
Yeah, and for surgical oncologists, there's only 60 something worldwide. So it's it's very small community.
Yeah, and it's really tough to get pet parents out to the areas where the densely areas where you have the surgical oncologist. That's one of my. I was trying to make that into dove that tail into the much bigger conversation about how there are just too few board certified veterinary oncologists in this country. Because as a pet parent, you know, I talk to thousands of pet parents, and the absolute number one complaint is, you know, I don't have veterinary oncologists in my entire state, such as the case of Arkansas or Nebraska or something like that. So we definitely need more board certified medical or oncologists out there in this country. So anything you could do on your end within your community to get more out there, that would be great.
That would be up to the guys that are training residents, right? So we need more residencies, and there needs to be funding for that. So the biggest hiccup is that there's not enough funding for universities to have as many residents as we should. Right?
Absolutely, it's a function of resources. Always a function of resources. But I'm friendly with Craig Clifford and Phil Bergman and a number of the people that are up there and have those conversations. I'm constantly on them. It's like whatever we need to do, whatever programs that we need to get into place to increase that population, because because financial considerations are a big concern for pet parents. And if you have to drive 6 to 8 hours to consult or get the treatment done, it certainly changes the treatment plan. And I want to get our goal. I think one of our side goals here at Fuzzybutts and Friends, and certainly with the Puppy Up Foundation, is getting as many pet parents to get at least the initial consultation with a board certified veterinary oncologist. That's like one of our biggest goals, because I'm sure, as you know, and I'm sure as you've seen, is that once you have that initial consultation, you have a much better chance that the pet parent will choose follow-on therapy, and therefore improve the outcome of the Fuzzybutt, the patient.
Right. I agree. I mean, cancer care has come such a long way. I mean, we're, you know, incurable things and inoperable things from before are no longer incurable nor inoperable anymore. So I think the threshold of cancer care too, like what pet parents want to seek out, has also changed. As cancer care, I think, has evolved in human medicine, and people can see how well human cancer patients are doing, they're seeking that out now. So I do agree. I think having more veterinary oncologists would be paramount to getting these pets treated. I think a crude estimation that I found in one of the websites is that 6 million in the United States, there are 6 million dogs and roughly 6 million cats that are diagnosed with cancer every year. Like, that's a staggering number. That's
the number that we're using, 6 million new cases every year. But it's also, if you look at it from a financial resource perspective, that's a lot. That's a lot. And we just don't have the funding in place to be able to get all of those beautiful dogs and cats treated. And that's why I think it's important for pet parents to know and understand the need for surgical intervention. I had a good friend of the foundation, one of our supporters in Bowling Green, Kentucky. She was diagnosed with a type of lipoma, metastatic or cancerous malignant lipoma and fatty cell tumor, and she was in her 30s. And I was discussing it with her when she made the decision to go through surgery first and not pursue the other treatment options. And her words, I'll adjust them for our audience, but she said, you know, I looked at it and I said, get this damn tumor out of me now. And that was sort of the decision-making factor, the determinant. I think, you know, what a great way to think of it, because we think of cancer as self and non-self, and it is non-self. So you want that thing out as quickly as possible. And that's why surgical intervention, it seems to me, would have much better long-term outcomes than non-surgical.
Localized disease, yeah. So the caveat being for localized disease. So we're good for local regional disease, local meaning wherever the tumor is at, and regional meaning nodes.
Right. Can you talk to our audience about the concept of clean margins, wide margins, so they can understand that part of the conversation?
Sure. Yeah, for sure. For nearly all of our malignancies, we don't just want to cut out the lump of cancer cells that are in front of us. And so we call that gross disease, meaning gross or visible level of disease. What we do know that for nearly all malignancies, you're going to have a scattering and a smattering of cancer cells radiating away from that lump that you cannot see. We can't pick this up. We cannot pick this up on a CT. We cannot pick it up on an MRI. This is a microscopic diagnosis. So in order for us to be able to remove the lump, plus any smattering of cancer cells radiating away from that lump, we have to cut out the lump plus a certain amount of normal tissue all the way around it. And so the biggest thing that we have to convey to pet owners, and they're always alarmed when I say this, is that for something like a mast cell tumor or a sarcoma, it's not just in the skin. Those tentacles are radiating not only 2 centimeters away from the skin, but they're also going depth-wise. So we not only have to get margins in the skin, we also have to get that first fascial or muscle layer or bone, if that's directly underneath bone, out with the tumor. Does that make sense? So that's our key for when we say we are going to operate with wide margins. You're looking at least 2+ centimeters, depending on the tumor type. It's anywhere 2, 3, 4. It just depends on what the cancer type is, what the grade is, how aggressive we're trying to be. So we get a certain amount of normal tissue away, skin-wise, subcutaneous tissue-wise, and muscle-wise. We get one uninvolved muscle or fascia underneath it, meaning if the tumor has breached one layer of muscle, we don't just remove that one layer of muscle, we have to get one more layer underneath there. So that's the concept of wide margin surgery. Radical surgery is where you're removing an entire compartment, because that's the only way for you to get the margins that you need. For example, amputation with osteosarcoma. That is not a wide margin surgery. That is a radical surgery. A lot of the jaw removal surgeries that we do, it's not just a wide margin surgery for something like a high-low fibrosarcoma. It's usually a radical surgery because we're trying to get 2+ centimeters on a jaw that is only maybe 4 centimeters in size. So you're looking at a radical surgery where you're removing an entire compartment.
And that's important too, because we know, Dr. Vinayak, we know that in most cases, it's not the primary tumor that kills the companion animal, it's the metastatic, the secondary tumor side. Is that the case? We see that a lot?
It depends. Some diseases, it depends on what the metastatic potential of the tumor is. So for tumors like hemangiosarcoma, absolutely. It's never going to be the primary site. If you remove the spleen, it's not the primary site that's going to be life-ending for that patient. It's going to be the metastatic disease. Same thing for osteosarcoma. What is life-limiting is the lung metastasis that develops over time. Can go to other places, but typically lungs is where we tend to lose the battle with osteosarcoma. But for certain tumors like squamous cell carcinoma, oral squamous cell carcinoma, the lymph node metastatic rate is 15%. Lung is only 30%. We're not dying from local disease. We're not dying from metastatic disease, sorry. We're dying from local disease without treatment. So without treatment, that tumor is going to get huge in the face, and that is life-limiting before we end up with metastasis in lymph node or lung. So it depends on the tumor type where we're going to lose the battle, in other words.
Right. I was thinking about when you were talking about jaw and radical surgery, I was thinking about Ginger's lovely kid that I got to know and love, Buddy. That was, well, Ginger, tell the story, and then I'll tell you the name I had for him.
He actually had MLO. And so they were able to do surgery and remove part of his jaw. He had already lost the sight in his eye. And so they removed his eye as well. And that, I would say, it was radical for me, you know, because it was just what he looked like immediately after the surgery. And Luke could tell his story, but you know, that's one of the things that I find is that the pet parent is not ever really like say, hey, this is what your dog is going to look like. Don't be afraid, they will heal. A lot of times, like when Luke was saying with Malcolm with the amputation, but with Buddy, Dr. Mann from the University of Missouri, sorry, I lost that for a second. He was like, we're going to make him look just as good as we possibly can. I'm going to do my best. And I'm like, you know, it's not what he looks like, it's his soul that I want you to save. But I'll let Luke tell you the rest of the story.
I just had my term of affection or endearment for him was Frankenbuddy, because he looked like they took the eye out, they took part of the jaw out, but he was still Bud Man. And I did want to speak to the fact that some pet parents might are reserved and a bit concerned about surgery because of the physical aftermath of it. But what I like to reinforce is you can't break the spirit of Frankenbuddy. It didn't slow him down. He was still chasing squirrels. So even and of course, as we know, that dogs don't care about what they look like. They don't care if they're three-legged, if they're missing a limb from cancer. So there is a need for radical surgery when it warrants, because the most important thing is you want to get as many of those cells as you can.
That's right.
What, Dr. Vinayak, speaking about pet parent education, what works for you? How do you educate when a pet parent comes to you for the first time and they get that diagnosis, liver cancer, let's just say, walk us through their process?
So I think knowledge is key, because the more they know, the more educated the decision they can make, and then they can figure out what actually lines up with their goals. So my job initially is, I don't even just launch into your dog has liver cancer. I actually explain what the canine liver looks like, what its function is. Then we talk about the cancer. Then we talk about why it's important with the diagnostics that we do. For example, I always recommend a CT scan, for example, if we're talking about the case of a liver cancer. So my spiel generally with liver cancer is, this is what a canine liver looks like. We think about it like it's a big blob of an organ, but in reality, it's 6 bananas coming together at a main stem. That represents 6 lobes coming together at a main stem, which is the highest main blood supply from which you have branches going to each banana or each lobe. And then we say, okay, there's 2 lobes on the left. We call that left division. There's 2 lobes on the right. We call that right division. There's 2 lobes in the middle, and that's central. And it's important to know where the tumor is, because that affects operability. Left division is notoriously more operable than right division. And for that, we need a CT scan. So this is my normal spiel. CT will tell me location and tell me how close to the main stem or the hilus we are, what lobe, what division, which then tells me ahead of time whether or not we're going to be able to get it out and what the risks are going to be with that. So I think it's anatomy, it's why we're recommending the diagnostics we're recommending, and then actually talking about the cancer and what the prognosis is going to be given, depending on what tumor type it ends up being. Does that make sense?
Do
I
you?
didn't know what is ringing here. Hang on 1 second.
Sure.
Sorry.
No worries. No worries. Do you? I'm
sorry. So and again, it's recommending whatever diagnostics it is that we're recommending and why we're recommending those diagnostics, and then based on those diagnostics, what options we may have. I think it's important to preface it, at least so they've heard a little bit about what options you're going to present, especially once the CT scan comes in. You never know what options you have for treatment until we actually get that scan, right? You can say there are surgical options, there are radiation options, there's, TACE or chemotherapy options that we can embolize directly into the tumor, but you don't know what options you actually have until those diagnostics come in. But I think it's important that they've heard that information at least once. Okay, they're going to be talking to me more about this, and this, and these are my options. And then when we come back with a CT scan, then it's easier because they have already heard, okay, now she's going to talk to me about surgery, then she's going to talk to me about radiation, and then she's going to talk to me about what it would be from a medical standpoint if I didn't want to go down the path of surgery or radiation. So that's a typical, I think, consultation. I think knowing everything there is to know about that tumor and then lining it up with where their goals are.
Do you require that the pet parent get a CT scan? Is that a requirement for your surgery candidates?
For a lot of the tumor types, yes. Like I won't do a skull or a jaw surgery without a CT for margins, for planning, because what you see oftentimes for those kinds of tumors is the tip of the iceberg, right? What we're seeing on the outside above the gum line is a fraction. And if I did surgery based on that, boy, would we do a big jaw surgery and do it all wrong.
Yeah.
Right? There's nothing worse than poorly planning and executing, because now you've left cancer behind and now you're looking at a revision surgery and on an already fairly aggressive surgery. Now, a revision is something no client wants to do after a jaw removal surgery, to say, well, we didn't get it all, so now I have to go back and take more jaw out, is never something a client wants to hear. So better to plan in advance for, especially, I don't require a CT scan for all tumor types, But for a lot of the ones that I do on a daily basis, I need a CT scan so I can have the best outcome. I can plan in advance. I know what margins I have to take. You know, ultrasound is great, but it does not replace the CT scan. You know, your probes can only go so far. You have a massive tumor, you're not even capturing all of it on your ultrasound probe screen. I cannot plan. Ultrasound does not give me what liver lobe it is, what location on the liver lobe it is, what division it is. I don't have any of that information. Now, having said that, especially when times are financial, there are times when we say, okay, if we go down the path of CT scan and now you don't have any money to put towards a surgery, that CT is no good because we have spent $2,000, $3,000 on a scan and then no money to actually fix the tumor, right? So we didn't do the client nor the dog any favor. So if we're in that situation, I always say you also have the option to just go straight to surgery. Then surgery becomes exploratory, meaning I find out what division, what location, and what my operability options are once I actually get into surgery. And that is not a wrong option either. So we always say, you know, the gold standard is we get a CT scan and then we go to surgery, and I give them estimates for both. I said, you can also take away the CT scan altogether and we go straight to surgery. But then I can't answer the questions that they have, which is usually, well, what are the chances it's going to be operable? Well, I don't know until I can get into surgery, right? What are the risks? And well, these are the general risks, but I can't talk specifically based on division.
I absolutely, and that's an important question, and I think distinction for pet parents is that first off, you don't always necessarily need the CT scan because that is additional money, $2 to $3 grand. But there are some of the complicated, more involved cases that warrant it or necessitate it, or your chances of an outcome are much less. But there are some cases that CT is just not, it's not necessary, absolutely necessary.
It's not absolutely necessary. Like,
And that is important because there are the pet parents, unfortunately, that I meet out there that still that's their dread. The reason why they don't go see the reason why they don't get their first initial consultation with a board certified veterinary oncologist is because they just feel like that they're just going to rack up the just like a la carte menu of all the carte CT scan, this, that, biopsy, so on and so forth. Unfortunately, cost is still a limiting factor in treatment decisions.
Right. I do think that it's important for pet owners to come in with an open mind and not have a judgment as to how chemo or surgery or radiation is going to be on an animal, just to come in with an open mind and to also come in with realistic expectations for a consultation. Oftentimes, all there is a cytology that says consistent with possible soft tissue sarcoma. This is a typical cytology readout. And I have no other diagnostics, but the questions that I will get asked are things like, how long has it been growing? I don't know because I'm looking at your dog at one point in time, right? If I do nothing, how much time does my dog have left to live? Well, I don't know because I don't know how far the cancer has gone and we need to do some diagnostics. Well, how aggressive of a cancer is this? I don't know because I need a small biopsy to know what grade of sarcoma this is so I can tell you better how aggressive this is. So unfortunately, to answer the questions that most pet owners have, which are difficult questions, and I think definitely warranted, that's good information that they should have before we take a big step like actual treatment. We unfortunately do have to do diagnostics. We cannot answer those questions based on one cytology, very similar to human medicine. You can't just do one FNA and then expect to have all the answers on that one document. You know,
Right.
we can't predict whether the cancer is inside the chest. I don't know that unless we image.
Absolutely. The way I like to when I speak to pet parents is that you need as much data and you need the best snapshot of what's going on at this moment. So then you can select the best tools or toolkits
Exactly right.
for the best outcome.
That's exactly right. You know, we have X, Y, and Z options for a particular tumor type, but if I image and I find that the cancer has already spread, I am not going to be recommending potentially those treatments. I might be recommending something completely different. Surgery may be completely off the table. Same thing with radiation. If we find that there is metastatic disease, we will skip the first two. So you don't know exactly what treatment you're going to be recommending until those initial staging diagnostics are done.
Absolutely. Well, we've covered a lot of territory and some of the cases. Is there any other new exciting areas of research that you're currently doing or other things that you'd like to share with the audience?
I think my biggest thing for pet parents would be to understand cancer is going to happen in 1 out of every 2 dogs over the age of 10. right? And pretty similar for cats as well. Please get pet insurance is my thing. Please get pet insurance when they're puppies and when they're kittens, and maintain that policy, as useless as it may seem, for the first 10 years. Pay that, because it's going to become important, and then you don't have to make a difficult decision of euthanizing potentially a curable cancer because we don't have the finances to proceed on with it. And it becomes too late once the diagnosis of cancer has already been made. It is now a pre-existing condition. Nobody will insure you, and nobody will cover that. And also know that not all pet insurances are created equal. You have to do your research, and you have to figure out what the best plan is and who has the best reputation for covering things, and then stick with that plan. So I would say that I really would love if our primary care veterinarians could encourage insurance to pet clients, because that's something, by the time I see that patient, it's too late, right?
Right. I just
Too
realized that. I just realized that when you were saying that, I was like, wow, by the time you get to them, it's too late. They already have to. So really the GPs are the gatekeepers for pet insurance.
That's right.
Yeah,
And so for certain cities, like I was in Chicago for a decade, right? That's where I was a general surgeon. 8 out of 10 clients had insurance.
wow.
Recession hit in 2008, and the rest of the country was struggle busing for veterinary care, because I mean, how could you afford to pay that when you can't afford to put food on the table and feed your children, right? Like it's a fact. Like we were all in rough shape, but not the Chicago market, because for those clients, they had Trupanion and they had VPI that paid 90% of that bill. So surgery and care continued fairly normally for the Chicagoland area. And I do think that it maybe is kudos to the Chicago veterinarians, because I was at downtown Chicago, like kudos to the veterinarians, because they had encouraged purchase of that insurance, I think, you know, when there were puppies and kittens. And I wish that was more prevalent, because I rarely see a client with insurance in California.
Wow. That's
I was,
wow.
I was recently at one of my own doctors, and he was saying that he was going to get a new puppy in the near future. And I looked at him and I said, pet insurance. And that was my first thing out of my mouth. And he said, well, you know, I had pet insurance on my other dog. And he said, I really think it was a waste. I'm like, wish I had pet insurance on my Lily that has 2 rounds of cancer, you know. And I kind of just threw out a number that I thought I had probably spent over the last few years. And he said, yeah, pet insurance.
Yeah, I mean, I have Trupanion for my cats, because like I don't know how expensive it's going to be. You know, one of them's 13 and he's already been through a couple of surgeries, you know, and thank God for insurance.
Yeah.
80%. That's a tremendous number. I what do you have any idea why Chicago the penetration rate is that high? And the first question and second question,
Yeah,
how
like,
can you,
you know, that 90% is like roughly what I remember it being. It's been a decade since I've been in Chicago, so maybe that's changed. But back then, I would say 8 out of every 10 clients would have insurance. Like it was fantastic back then. And I was like, you know, kudos. I've never been in a place where nearly every client had insurance. And then I thought every big city, it was stupid me, but I thought every big city would be like that. And then I come here and here I'm in LA, Orange County, and like virtually no one has insurance. And every day clients will ask me, can I now get insurance? And I always tell them, it's now pre-existing, it's too late. They won't cover you and they won't insure your pet. So now we're stuck with this big bill. And I think that really does affect the percentage of patients. We could do a lot more and we could treat a lot more, not just with cancer, just with diseases in general in the veterinary population, if those pets were insured.
yeah, I'm of the mind of, if it works, let's replicate it. Let's see if we can reproduce it in other areas where we're not having that success rate. So I am really curious about what they've got going on in Chicago. And I thought maybe you might know, like, say, for example, like the Cook County Veterinary Association, they really are pushing pet insurance.
Like it's not so much the Cook County, like the local VMA organization, but I think it's the general practitioners. Like I've gone to Blum Animal Hospital and a lot of them down in Chicago who are my normal referrings, and they all have insurance packets up front, right at the front desk. And so they must be also discussing it with clients, saying, this is your time to get it. Pet care is expensive. So, you know, I think it's a great topic for someone probably not me, but someone to, from the insurance side of things to come in and talk about why it's important and when to insure and to look at carefully, because not all plans are created equal either. I also have clients will come in and say, I only have $3,000 per year, and what can I do for $3,000? And that becomes really difficult because oftentimes just with staging diagnostics and the initial biopsy, we eat into that a lot, and then we don't have, and that information is important because that affects the next step. I do need staging. It may not be a CT scan, but we still have to do some kind of staging to determine extent before we jump into treatment, because it affects treatment decisions. And if we use up all the money that we have, then we don't have money to actually put towards the treatment. So I think it is important to not only purchase insurance, but to look at what plans there are and various degrees of coverage. And to ensure, even if your older pet doesn't have cancer, that's the other thing I have clients tell me, they tried to insure their dog the previous year before it got cancer. And what they were quoted was outrageous. Yes, because it's now a 10-year-old dog, and in insurance's mind, a dog that's now likely to get cancer soon.
Right.
So premium then is high. So the key is when you get it when they're puppies and kittens, it doesn't go up very much year over year. But when you purchase it when they're 10, now it's an expensive plan.
Yeah, I would imagine that's one of the great things that VCA can do, because with 25% of the market of pet parents, you would hope that they would be pushing pet insurance from day one, that when the client comes in. So, Ginger, that just it's a bit of a sidetrack, but we need to have an entire episode here on Fuzzybutts and Friends on insurance, different plans, and help, because that's, as you know, financing is kind of the key to everything, unfortunately, in this world. So
I have been in contact with Trupanion. I need to reach back out to them, but I don't know. I'll figure out how we can discuss different plans, but that might be difficult.
We have certainly covered a lot of topics. Dr. Vinayak, is there anything else that I missed or left out that you think is of importance for pet parents out there?
I think, as I said before, I think knowledge is key. So coming in for an oncology consultation, I think, is paramount, but educating yourself at the right sites is also key, because there's a lot of scary information, right? Dr. Google is a pretty scary thing. So you don't want to just go into Google search bar and type in MLO dog, because what may come up may be quite alarming and may deter you from actually pursuing treatment. Like MLO grade 1 MLOs, I have lots of patients that are great years and years out, right? But maybe if they just done Dr. Google, they might have gotten scared away. So some good websites, I think, and especially for clients who are very academic and they want all the research that's published out there on a particular topic, I would recommend going to PubMed.com. Just go to PubMed, and it's a very easy search bar. You can type in oral squamous cell carcinoma dog and hit enter, and up is going to come all veterinary publications on that topic. So you can educate yourself the right way. What is the complication rate? What are the procedures? If my vet's recommending saying that I should go see a surgeon for a mandibulectomy, well, what are the complications of because that sounds very scary. But once you get on that website and you realize, well, the complication rate is really low and the outcomes are glorious, you're educating yourself on the right website with published information and research, and you're going in with, I think, a better frame of mind rather than just Dr. Google. So I'm not saying that you have to do that, but if you're going to get on the internet, it's important to go to objective information rather than subjective information that may be on Google. I think that PubMed is a great thing, great site. Another good website is VSSO. It's the Veterinary Society of Surgical Oncology. VSSO.org. Like, you go to the website and there is tumor information by site as well as type. And it may not be the most current information because they're still updating all of the tumor types, but it gives you some really good objective information. So you don't have to pour through PubMed. It gives you the nitty gritty. Okay, my dog has been diagnosed with osteosarcoma of the bone. And so you can just literally go to tumor type or site and just click on that. It gives you information. You can read up on osteosarcoma. You have a good idea coming in what's going to be said to you. So it's not information overload at one time. You have seen that information once before, because I think it's very easy to be overwhelmed, especially with the amount of information that is relayed at each of our consultations. I tell my intern this all the time. If somebody were to sit me down and tell me all of this, if I was diagnosed with cancer, I would be overwhelmed, to say the least, right? So I think it's easy to get overwhelmed, and it would be great to unoverwhelm them if they can be better prepared for that consultation, maybe with some objective information. And then when you come in, you're hearing it now, it's getting reinforced for the second time. And then you're in a better boat to be able to make a solid decision, whatever that is for your pet.
Absolutely. And I got to say it again. I can't say it enough, is that as soon as after you're done, I would say before you get on Dr. Google, but immediately after you're off of Dr. Google, contact your GP, get a consultation from a board certified veterinary oncologist, because that's not only is that where you get the highest quality of data information about the type of cancer that you suspect that your kid has, but also the vast majority of veterinary oncologists that I've met, they just have such tremendous bedside manner, and they'll help you overcome that feeling of dread and fear that we all have. I've now had 3 dogs with cancer, and I almost die every time when they get that initial diagnosis. Even I've done this several times over. So know where to find out information, and then more importantly, go to the people that have the information. And that if you can and have the ability, even if it's a little bit of a drive, find your nearest board certified veterinary oncologist out there. All right, Dr. Vinayak, is that anything else?
I can't think of anything else, but you can tell me if I missed something.
I think you were great. Did a lot of information. I have a ton of notes here. It's hard to read my scribble and questions. I'm just trying to make sure I got everyone. Can you tell us the name of your clinic again, and maybe the website to promote that out there? And
yep. So if you just go to Google and you type in VCA West Coast, it's going to come. So our hospital is VCA West Coast Emergency and Specialty Animal Hospital, and we're located in Fountain Valley, California.
Because if I'm ever out there on the West Coast and I'm in a jam and I have one of my kids is a surgical candidate, I'm going to come see you, because I love your passion. I love your passion. I love that you love research, and you're on the forefront of innovation, technological innovation, because as you said, that's the most important thing. We always have to be improving our outcomes for our fuzzy butts.
Yep. I think there's so few comprehensive cancer care centers that have medical oncology, radiation oncology, and surgical oncology in one building. And we are I think we're the only ones for sure in the state of California, and I think only 1 of 2 in all of VCA that have all 3 oncologists. So the advantage, because that's usually a university thing. CSU has all 3 types, right? Missouri has all 3 types. So you have a few universities, University of Florida, Ohio State, you have a few universities that have all 3 types, and that's it. Not even all the universities have all 3 types of oncologists. So to replicate that, in private practice like that, we started with this hospital when it was brand new, to specifically come in and set up a comprehensive cancer care center. That's why we have so many different kinds of oncologists, and so many of us, so we can see the volume of cancer patients that are in LA Orange County and help as many patients as we possibly can, and get inputs from everybody, because we're constantly getting inputs from each other. Patient comes back, medical oncology is receiving at the same time, radiation's got their schedule at the same time, we're all seeing appointments, and we're all sharing information at the same time and getting all options for all of our patients. So it's a great facility. I wouldn't trade it in for the world, for sure.
That's wonderful. What is your patient load?
I think in terms of surgery in a week, anywhere between 8 and 12 surgeries I do in a week, depends on how complicated. So a slower week is around 8. A really busy week would be around 12. So that's on 2 operating days, and then 2 days are appointments for me. So it's a 4-day, 14-hour workday. And that's what we do. We see appointments on 2 days and rechecks, consults and rechecks, and then 2 days of operating day, full day.
That is a lot of surgeries per week. What is your your patient load for cancer patients in general? Do you have an idea about that?
I'm not sure I think a lot. I see, in terms of new consultations, I see anywhere between 30 and 40 new consults a month. And each oncologist is seeing relatively that same amount, and there's 5 of us. So I think a low ball number, 30 consults times 5, it's probably 150 new patients at minimum a month.
Right. Wow. That's something else. Well, I think the takeaway, one of the many takeaways from here is that we now know that there's a coin flip of a chance that your companion animal, your canine companion is going to get cancer in their lifetime. Be prepared, have insurance, and then know the resources and where to go, such as the wonderful facility out in on the West Coast that you guys have there at VCA. All right, we're wrapping up. We ran a little long on this one, but there was so much data. It was a wonderful dialogue. Ginger, I always like to wrap up the show with the Puppy Up Foundation Cancer Tip of the Week, but that's all we've been talking about this episode. So in lieu of that, did I miss anything, leave anything out, or did I screw anything up this time?
I don't think so.
Or
I
were
think
you
you did
even,
all right.
were you even paying attention? Were you even listening to me?
To you, yeah, I did. I did.
All right. Well, I think we've got it covered. Dr. Vinayak, you're truly a friend of the Fuzzybutts. Thank you so much for taking time out of your very busy workday schedule to talk to us here on Fuzzybutts and Friends. You're always welcome back here on our show. If you've got new research that you're doing, something new, exciting, or a new program that you're launching there at your VCA clinic, you're always welcome back here.
Awesome. Thank you so much for having me. I appreciate it.
And thank you, everybody, for joining us this week. Thank you, Ginger, for joining us.
You're welcome. And thank
you
you for coming in. Yeah.
Thank you for showing up. All right, everybody. Thank you. Thank you. Definitely thank you to our audience, our ever-growing and increasing audience. We're getting many more viewers and listeners to Fuzzybutts and Friends every week. Thank every one of you. It's going to be a great season 2, 2023. So we drop our episodes every Tuesday. You can watch it live, or not watch it live, watch it on our YouTube channel at fuzzybuttsstudios.com, or you can find the audio on your podcast platforms such as iHeartRadio or Spotify. That's it for this episode. Talk to you next week. Puppy up. Talk soon.